Good morning to everyone, and it is a real privilege to be here on a Sunday morning talking about dental research. And so what the organising committee asked me to share with you is the work that we've done to understand what is an AGP and does the world agree? And what I'm going to do in order to demonstrate this is share with you really examples of collaboration that your dean has just mentioned that has become evident worldwide during the pandemic. I'm going to focus on the work that the Scottish Dental Clinical Effectiveness Programme have achieved, working alongside Cochrane Oral Health. And as you know, we've got a very close relationship between the two programmes of work. And I think what I'm going to demonstrate to you today is just what can be achieved with a little bit of creation and energy. So, I'm sure many of you will have taken part in quizzes online. This is an example of a quiz that I took part in at the weekend, and this is to guess the artist. Now you will see that the artist likes to remain anonymous. They are famous for creative pieces that are done rapidly. They are very, very sophisticated and look like it's effortless. And the two that are most recognized is a girl with a red balloon and policeman kissing. And as you can see by the wall, it is a graffiti artist. And I suppose a graffiti artist, they make their work available to anyone, and it's open access, but also they deal with aerosols. And I suppose unlike graffiti artists, for dentistry, an aerosol is a different issue. And the first thing that we need to do is to understand what an aerosol is. And for dentistry, an aerosol generating procedure, you can see is defined here as any dental procedure that results in the production of airborne particles. And the airborne particles is the aerosol. And a procedure is any dental activity that uses a particular instrument. And aerosols come in two types of particles, and they're defined by their size. Droplets are the larger and heavier ones that are greater than 5 microns. And these can travel up to 1 meter from the source. So if you imagine the patient, it really is around the chair that they contaminate surfaces in that range. However, there are smaller droplets, and these are droplet nuclei, which are smaller than 5 microns, which can stay airborne because they're not as heavy for longer periods of time and travel further. Now, what the pandemic has demonstrated is the importance of understanding the transmission of biological components within an aerosol. And an aerosol could contain bacteria, fungus, and viruses. What's happened since sort of like the 60s and 70s, people have measured the contamination potential of aerosols. And usually that is measured by bacteria. And also the diffusion or reach of an aerosol is measured with a luminescence or fluorescence in the component of the water through instruments. But most of the research is done on mannequins. And what we do not know, and we still do not know, is the real risk of SARS-CoV-2 transmission through aerosols. But as has just been described, the fact that you have not been able to access clinical care, providing clinical care within the dental hospital is a result of the concerns of the potential spread of what we're all realizing is a very serious, serious disease. Now, so aerosols. Everyone, I think, would agree that this is obviously an aerosol and an instrument that creates an aerosol. And what needs to be worked out is the implications of this going on in a patient's mouth. And in particular, whether or not they're asymptomatic of this disease. And I suppose it was really in March last year. That is when the questions started to occur, is what does dentistry need to do differently? And there was genuine confusion. And so this group of individuals, and I think you'll recognize some of the faces, your dean here, Anne-Marie, Manus, who you'll be hearing from, I think, after me, we got together. And I suppose this is a demonstration. This is sort of like you're interested in research. And I really believe anything can happen. And this stemmed from a Friday evening's conversation. Why don't we examine what is happening in the world in terms of AGPs, and do people agree? So we embarked on what we call the Coders Review, which is a rapid review looking at the international dental guidance documents around aerosol generating procedures and what the mitigation actions were being taken. We found guidelines in 63 countries. And, sorry, not 63 countries, 63 guidelines, because, I mean, look at the size of the UK. There were actually 4 documents from the UK alone, which I'll come back to in a moment. And what we searched the guidance documents for was information around AGP. So the first thing that we looked at is whether or not they included a definition of an AGP. Actually, 56% of them did. And as you can see here, almost all stated that AGPs could be provided for non-COVID patients. Interestingly, the only guidance document not to do so was the one that was produced in Scotland. Now, for the 56%, which actually equates to 35 of these guidelines, in terms of an agreement on what was an AGP or not, you can see here that all said that a 3-in-1 syringe and high-speed handpiece was an aerosol generating procedure. However, as you can see from the figures below, there was variation in what other procedures were considered to be an aerosol generating procedure of risk in dentistry. In terms of the mitigation, again, there was variation in the recommendations of PPE. As you can see here, the masks of FFP2 or N95 were recommended by 70% of the guidance documents. Interestingly, I'm sure you're aware that when you are undertaking aerosol generating procedures in the hospital, that you are required to wear an FFP3 mask and to be fitted for it. There was also variation in procedural mitigation. And what was most recommended in these guideline documents was a mouthwash. And interesting, and it's a different story, but the Cochrane team and Cochrane Oral Health working alongside ENT were firmly established that there is no evidence for that. As you can see, rubber dam, again, was recommended and high volume suction. And what I suppose is interesting is that if you were using a high-speed drill, you would not use high volume suction. And so we need to understand how these procedural mitigations truly work and bring on additional benefits for mitigating the risk of transmission. Environment is what everyone is speaking of today, and ventilation is probably on every news bulletin. As you can see here, it was just over half of the guideline documents mentioned ventilation. Some other devices, air cleaning devices, but maybe the issue that impacted most on the delivery of care, certainly in the UK, was a fallow period. In the UK, it was 60 minutes. What we found from around the world, that actually only 48% of the guidelines recommended a fallow period, and that varied between 2 minutes and 180 minutes. And what is important is that we examined the evidence underpinning these recommendations. And actually, generally across the board, there was very, very little evidence, and in the main, non-existent. So there is variation around the world. Could maybe the prevalence and mortality of the disease explain it, or could actually income explain these variations? And this is what we investigated, and you're the first to see these results. And as you can see here, there are small variations between countries in terms of their death rates, whether it was a high death rate due to COVID, medium or low, and whether or not the World Bank considered them a high or a low to middle income country. And we looked at the minimum mass recommendations and also not recommending a fallow time. And statistically, there are no differences. So there is nothing that really explains this world variation. And what is increasingly important in this time is that we do all work together. I mentioned that the Coders review contained multiple guidelines or guidance documents from the UK. And in fact, there were 6 published within the space of 10 days. Now, when you come to research waste, that is one of the best examples of waste. And as you can see here, I've highlighted Manas's name. He was one of the key individuals who took this work forward. And actually, the consequence of this is that a new group formed. This is the SDCEP AGP working group. And it is a vibrant community that still meets every 6 weeks. And I think it was within 13 weeks, we produced this document, Mitigation of Aerosol Generating Procedures in Dentistry, a rapid review. Now, I'm sure you're aware of the methods of a rapid review, and they are the ones that we applied. And it was important to work alongside Cochrane Oral Health. So there was a systematic search of the evidence. We were looking for guidance and systematic reviews in particular. Everything was identified in or examined to screen in duplicate, and then data were extracted that was relevant. Unlike SDCEP's usual documents where we make recommendations, during a pandemic, it's only the governments that can produce and publish guidance. So we produced judgments, considered judgments. So we took into consideration the balance of harms and benefits, acceptability, feasibility, preferences, and values in order to make the recommendations around what was an aerosol in dentistry, whether or not there were different risks associated with different aerosol generating procedures, and the procedural and environmental mitigation. And I think maybe just like a graffiti artist who puts up something surprising, I think our definitions around what was an AGP of risk within the pandemic surprised people. And as you can see here, that the ones of likely to be a potential risk, we did not include the 3-in-1. It did include the high-speed drill and the ultrasonic. Like a graffiti artist too, actually coming up with that image that actually describes and portrays simply a huge amount of work in the background. That is what we did before coming up with this flow chart. And as you can see, of prime importance here is around ventilation. And the first question being around ventilation rate, and if there is none, you would not proceed with one of the Group A procedures with a high-speed drill. And then you would consider the number of air changes. And the question would be whether or not you use high volume suction and rubber dam. And certainly the evidence from the Cochrane systematic reviews for high volume suction and the rubber dam is clear. And what we concluded is that this should then reduce, if those mitigation procedures were in place, they would reduce the fallow time. And so our recommendation was that rather than 60 minutes, having considered all of the evidence, and in fact, where there was a lack of evidence, that this could reduce to between 30 and 10. What's important to mention here that these decisions were not made just by dentists. It included people from the National Physical Laboratories, aerobiologists, virologists, and so we were working with the UK's experts in this area. And I suppose when I was an undergraduate, the most exciting thing was to imagine producing research. And then, I don't know, it was just, didn't even think that people wouldn't use it. Well, that's not the case. Absolutely. There is so much waste in evidence not being used, and that it can actually take 17 years. Well, this took 2 weeks before it was incorporated into the Public Health England's COVID-19 Infection Prevention and Control Dental Appendix. And that was an amazing feat, and credit to all of those involved for being involved and producing such a high quality product. And so this now became UK-wide guidance issued through governments and supported by all the chief dental officers. But I suppose the question is this going to continue and how long for? And another example of where this group has been creative and why we meet on a 6-weekly basis is that we're continuing to monitor the world's evidence that is emerging around the risks of AGPs. There is still no evidence around the viability of SARS-CoV-2 within a dental aerosol. And so we are monitoring because the impact it has had, and again, here is data being seen for the first time. And what this graph conveys are the number of courses of treatment, and this is Scotland. And as you can see, there was a dramatic fall by 94% in March last year. It has increased, but certainly not to pre-COVID times. The figures may be slightly different, and I would expect maybe in England it could be higher. And also what has changed is the prescribing of antibiotics. And all the work that had gone on in trying to reduce the prescribing and antibiotics, as you can see, there was a dramatic change in March. And actually that is continuing. And so there, I think, we need to understand why that is and work towards reducing. So guess who the artist? And it's Banksy. Oh, it's amazing. This was revealed Monday last week. And this is on the wall of Reading Prison. And this is supposed to be Oscar Wilde escaping. And the work is called Create to Escape. And on the right-hand side, actually for the first time, it was filmed to show that it was, and as evidence of a Banksy. This work required so much preparation in terms of behind the scenes to effortlessly place on a wall for everyone to see in terms of open access. It is also political too, because it's encouraging Reading to convert this prison into an art space rather than block of flats. And I'd like to think that actually Cochrane Oral Health, working alongside Scottish Dental Clinical Effectiveness Programme, are having similar ambitions. We're wanting to support the dental workforce going forward and providing the highest quality evidence in the most rapid way possible, being open about what we're doing and certainly sharing it with the world. And thank you very, very much for inviting me to speak this morning. Thank you.
Thank you, Prof. Clarkson. I will now hand it over to Mabina to ask any questions.
Thank you, Professor Clarkson, for such an interesting talk. You've actually answered quite a few questions as you were going through, but there is one, and that's, has the rapid review influenced international guidance?
It's interesting. So certainly the rapid review, what we know is that it's shared, and the coders review, all of the chief dental officers across the UK, America, Canada, and New Zealand, they contributed. It was shared through WHO to the world's chief dental officers. In terms of, I mean, well, I suppose in comparison, so the Banksy video, that has been accessed by 4 million people in the space of a week. Now, we were really delighted that the coders review and the SDCEP reviews, they've been accessed by 500,000. And that is enormous. In terms though, to be direct with your question, in terms of evidence that it has impacted on guidance around the world, I do not have that and actually haven't looked for it. But certainly the feedback that we do get is, and I think in part it is about the respect and regard that people around the world certainly hold Cochrane Oral Health in. And in terms of SDCEP too, there's trust around the recommendations that are coming out. And I suppose to emphasize too, what your dean spoke about, we experienced a totally different engagement and willingness of researchers to share. For the SDCEP piece, we were being contacted by different research groups. They were sharing their evidence directly with the working group, which included representation from the BDAs, the specialist groups, not only dentists, but dental health professional groups. And I just hope that that is going to maintain. And currently, we're now working with the chair of the SAGE Ventilation Group, Kath Noakes, to try and bring more evidence and information around ventilation for the profession.
Oh, perfect. Thank you so much. We do have one more question. And in your opinion, do you think that dentistry will ever return to a quote unquote normal?
Normal. So I think, I suppose maybe it will be a new normal. I think, I imagine that maybe the levels of PPE will be beyond pre-COVID in terms of the sort of like whether it's an FFP2 as opposed to an FFP3. So I think that may be here to stay. I think there will be issues of sort of like infection control, but actually dentistry as a profession have the highest levels of infection control. I think one thing that will change, and that is why too, I'm keen that we continue monitoring the evidence, is to actually understand the rationale and logic for the fallow time. And I think once that potentially changes, there will be, I think, a greater return to normal. I mean, what's interesting is a variation across the dental schools in Dundee. The dental students are going to be operating in a pod. So it's like a pop-up tent. What the dental students in here will be working. I know it's very different. And many of the dental schools, the variation that as dental students you will be experiencing are around issues of general ventilation. And there is going to be new guidance around ventilation for new builds. It won't impact on the buildings so far. So I think there will be changes. The speed of change, I'm not sure about. But I'd like to say that we are doing our best to make sure that it goes forward in a safe and evidence-based, informed way.
Thank you so much for taking the time. One more question, and it's going to be the last one. What do you think the reasons are for an increase in antibiotic prescription?
Right. So I suppose I think first of all, it was absolutely the response to the AAA message. So the AAA message being sort of like advice, analgesics, and antibiotics. And certainly as well, in terms of patients last March having access to dental care, often it was dependent for urgent access to care. It was dependent on previously having had antibiotics. So I think that it was a very crowded space there. I think in terms of why it is remaining so high, I'm not entirely sure. And that is where we do need to understand more. And certainly in Scotland, we're about to do some work in order to understand that and actually work with practices around antibiotic prescribing. We're hoping to embark on a national randomized control trial that's using audit and feedback and presenting dentists with their own data, like as a run chart, to then sort of like engage in understanding, and I think it will be reducing. I could go on, but I won't. I've just seen Manas, and I'm sure we're running out of time. And it's lovely to see you again, Manas. And I know Manas is going to talk to you about being an undergraduate. And I suppose, I don't know what he's going to say, but Manas, his involvement in the work that we did was really, really significant. And it happened because he asked to get involved. And I suppose that is my final message, is don't hesitate to ask people to get involved in the research. And quite honestly, it's a lot of fun working with good people.